I'm Dr. Demetrio J, Aguila III, and I'm the host of the Direct Care Movement podcast, where we talk about the intersection between money and medicine. Two topics that most people don't typically want to bring together. It's kind of like oil and water. We're going to discuss questions today regarding where these two intersect, what they have to do with each other. We're going to dive into questions that maybe you've wanted to ask, but you didn't know who to ask or how to ask or where to ask, or even if you could ask. And then we're also probably going to dive into some questions that maybe you do want to know the answers to, but you didn't even know that the question existed until we bring it up. We're going to discuss that and a whole bunch more. And I'm excited to have today as our guest, Tyler Hall. Tyler, thank you for joining us.
Thanks for having me.
All right. Tyler, why don't you tell us a little bit about yourself?
No problem, man. Yeah, I've been in healthcare beginning as a tax practitioner, actually, since before the Obamacare implementation of healthcare. So in 2012, I was working in Anchorage, structuring what was health reimbursement arrangement, Section 105 plans for employers in the oil pipeline or the periphery of the oil pipeline. There's a lot of businesses there that have various functions for that, and wanted to structure benefits for their employees that were tax advantaged. And so I've built and sold a few different specialized accounting practices since then, and 2 years ago founded CommonCare, which is tech solution, software-based solution for structuring group health plans and allowing a group to administer their own group health plan, which might sound kind of pedestrian, but nobody does this. You know, when an employer decides they want to offer a health plan, they kind of go to point solutions, they go to a carrier, and the carrier kind of puts the plan together for them, and that all becomes like a legal Frankenstein set of ERISA governed benefits for this employer. And if they just started like generating, or in our case generating, if you could start writing your own plan documents, that's what a group health plan actually is. It's a legal agreement for compensation between an employer and their employees, and like a payroll process, and then some tax decisions need to be made about how the benefits are going to be treated, and all of that is fairly complex for a group to tackle. So we started building software to generate plan documents that would free a group from the need to go to a carrier to structure their group health plan. And since then, we've gotten our fingers into other things, including direct primary care, kind of, you know, the spearhead of the direct care world. And so that's how I'm here, or why I'm involved in this space.
Awesome. So now, keeping in mind that our audience is primarily physicians or physicians in training or physicians to be, I'm familiar with a lot of the stuff that you just mentioned because I've been, doing a lot of this work through the Free Market Medical Association. But I think probably for some of our listeners, they might be thinking, that sounded a lot like Swahili to me,
Yeah.
I mean, maybe some of our listeners know Swahili. I only know a couple phrases in Swahili, but so let's dig into some of the terminology and maybe some of the general concepts. Like, obviously we're here to talk about direct care, and so most of what you just said has to do with employers. And of course, I think some of our audience is probably thinking, well, okay, so what do these employers and what they're doing have to do with me as a doctor?
Yeah. Well, given that employers and insurers own virtually 100% of the wallet share in healthcare, it has a lot to do with everybody, because that's what they have the gold and they make the rules,
Sure.
And that's kind of the only reason anybody should care about it. A lot of it is nonsense. It's just wickedly complicated regulations, middlemen, bureaucracy, and whatnot. So in some ways it just exists. But yeah, employers are a major payer of healthcare. Most of them they think that they're not in the healthcare business. If you ask them, hey, you want to get into the healthcare business? They would say, nah, we're a metal fabricator. Why would we get in the healthcare business? But they are in the healthcare business. They have their own risk pool under the Affordable Care Act, meaning they have their own actuarial value, meaning they have kind of a little mini panel in medical terms. They have so many cancer risk consumers on their panel. They have so many people that need this surgery or that surgery. They have their own risk pool. They're underwritten as such. They don't, unlike the public exchanges or marketplaces, they have their own little risk pool. They don't know that. They wouldn't know where to get their numbers or how to define their actuarial value as a plan, but so they are. And so that's something that's really confusing to them. They think they're not in the healthcare business. They are definitely in the healthcare business. They have just fully outsourced it to UHC or whoever, and those guys are managing it and they're writing the check. So they're buying healthcare from an insurance carrier. They're reselling it to their employees through payroll. They're calling it a benefit. And that kind of sums up the bulk of like the group benefit space. That's what's happening. So they are a major payer, although the insurance carrier is handling their policies, procedures, prior auth denials, so on and so forth. That's only because the employer has chosen to turn that over to the carrier. There's no de facto reason why that should happen other than complexity.
Right. Exactly. And so, and I'm glad you brought up this concept of the employer being the major payer. So very often when we have these conversations with doctors, especially doctors who are a little bit more savvy about how the business runs, they say, oh, well, we have this mix of payers, and they'll list off, I won't name specific companies, but like United Healthcare and Blue Cross, and we'll modify those. Obviously, they'll list off the BUCAs, right? The big four, the big five, right? And they'll say, oh, those are the payers. Well, the reality is, like you said, they're not actually the payers, right? Who's actually paying? The people that are actually paying are the employees and the employers, and they just use those health insurance carriers as a vehicle, right? Or the way I like to think of it, and tell me if you disagree with this, is that when you come in, if I'm a patient and I have United Wealth Scare, and I come into a doctor's office, I say, here's my card. Look, see, it's got the logo on the bottom. I have good insurance. Well, that's just like going to to Best Buy and saying, look, I have a MasterCard, or I have a Visa, and Visa doesn't actually pay the bill, right? It's the bank that the bank uses Visa as the vehicle by which the bill gets paid, but the money still comes out of the bank. And so the employer is they're the bank, right? But whose money is the employer holding? Your money, my money, the employee's money, right? That's ultimately what this is all about. And that's the reason you mentioned all these regulations. Those regulations are in place because the employer is spending money on behalf of the employee as a retention tool or as a recruiting tool. Does that summarize it okay?
True. Yeah. People, it's like a novel piece of information to explain that employers don't actually pay benefits, employees do.
Right.
But what you're saying is true. That this is it's as if you showed up to work and your employer, before you got there, they're like, we have a food plan. And you're like, okay, food plan, that sounds cool. And then you come to find that they're just spending your grocery bill for you, and they're choosing and not you. And people would be incensed about that. And they're a little less clearly incensed about their health insurance. They want to hear that the employer offers a benefit. But if you ask employees who are working and receiving those benefits, would you rather have this money and choose how to direct it, or are you perfectly happy with how your employer is spending your compensation? Over 90% of them will say, I'd rather have the money and direct it. So it's weird. It's perceived as a benefit like during the hiring process, I guess. It's because it's just like murky, and they're making decisions about compensation and they're trying to figure out what to do. But once they get in there, it's like they offered a meal plan and then they served terrible food every day. No, people aren't going to be happy with it. They're not happy with it. So we're at a weird juncture in terms of payers and like perceived benefit right now. It's a weird time.
Oh yeah, for sure. Well, and you touched on this a little bit. I mean, there's a lot of frustration going on now with respect to healthcare and to health insurance, and those aren't the same thing. I mean, there's a big difference between healthcare and health insurance. Health insurance is a way to mitigate risk associated with high costs, but healthcare that's a completely different conversation. I mean, that's me as the doctor trying to help you as the patient. So
yeah.
So tell us where you fit into this conversation and where your company fits into this conversation about doing things a better way, particularly as it pertains to direct care.
Yeah. So saying that, we talked about an employer being a payer. Say you get it with a self-funded employer who is presumably not having the insurance company pay for their claims, other than like maybe something that's really large. Maybe they have, some stop loss insurance that's in place. If, they're not a very large employer, they probably do, even if they are very large. But they're paying most claims. They're actually remitting the checks to the doctors, hospitals, or otherwise. They're not. A third-party administrator is doing that, which sounds like third party, like third-party accounting firm, someone that works for the employer to cut these checks. No, not quite. Third party is third party to the insurance carrier, who in this case is probably like ASO, administrative services only, from the same 4 major carriers that you were discussing earlier. So they're charging a per employee per month to set the price and move the money, or they carve some of that out and they have a third party private company that does that for them, but they're licensed through the insurance department, appointed with the carriers, and they adjudicate for the employer. So it's still the insurance carrier that's setting the price, which is an inflated price, which we can get into all the reasons why that is. And, it's not a conspiracy. All you have is alignment and pressure, like that's all you need. And so that's what's happening. Even if the employer is self-funded, they've got a huge deductible. They're still not directing care. If I were a doctor and I wanted the smoothest process to practice medicine, because I care about money, but I also care as like a practitioner of science and medicine to write my own course forward a little bit. If I would want to work directly with individuals or employers. Employers is a great way because you can get 20, 30, 200 individuals in one place. And so because of that, I would want to work with an employer that was paying their own care, but not if it's still being negotiated and adjudicated by the insurance company. Well, if you go to an employer and explain all that, they're just going to be glazed over in 2 sentences. They won't understand that. So my CommonCare allows an employer to create a group health plan, issue plan documents, enroll employees, and adjudicate claims outside of the insurance network world. So it's just lowest negotiable cash price network. Yeah, we can support insurance networks because some demand it, but we will pretty much require that they have at least one plan that they offer to their people that is a no network plan that allows for just the lowest negotiable cash price, direct pay to the provider for services. Yeah.
Okay. So then this all sounds great for the employer and for the employee. We're saving the employer and the employee a whole bunch of money. But what's the upside for the doctor?
Yeah. You can't empirically say, since there's no transparency to what doctors are getting everywhere, but I will say that anecdotally, my experience is you go get a surgery, you pay $40,000. The surgeon got $2,500. There's $1,000 in hardware. Where did the rest of the money go? Well, it went to a facility. Who negotiated that? Well, a combination of the hospital and the insurance company. And it's complicated why they would want to negotiate that, and why the insurance is willing to allow for a very high fee, and why the hospital needs them to do that to balance out their payer mix. Dang, well, why couldn't the surgeon make more, the facility make less, and the patient get way more perceived value, less middlemen, less going on for them to have to pay for, and the surgeon makes more money and can focus more on each case and doesn't need as large of a panel in order to make the money they want to make. That's what's needed, and that's what surgery centers and other places are doing. They're taking in people as fast as they can get them and whatnot. We're just trying to organize that a little bit. So that's what the group should want, but it's also what the physician should want, because higher prices, doctors just are not price gougers. Of all industries I've ever worked in, I have found medical professionals to be some of the most price conscientious for the value they provide, which is great economics, but it's not serving them because patients don't actually experience that good faith. They don't experience the generosity of the doctors. They experience people who take advantage of that and stamp a bunch of fees on top of the doctor. And
For sure.
yeah, so
For sure.
that's why a doctor should care, is because there's pressure for whatever you provide. You don't want to talk about money in healthcare, but it's just the reality of the conversation. So there's pressure on you to deliver value that includes a bunch of middlemen, and the more of those you can cut out, the more direct value you can provide to the patients. The more you can get paid, the less they have to pay, and that's some balance of that is exactly what you'd be looking for.
That's awesome. So then what we're talking about here is a situation in which the doctor sets the price, right?
Doctor sets the price.
And then obviously
the more they set the facility, the more they set the price, I should say, because some facilities are still going to be difficult in that regard, but the more the doctor has the lateral ability to negotiate the bundle that they're charging, including the facility fee, the more they set the price. Yeah.
Sure. And then obviously it's up to the employer and the employee to decide, okay, are we willing to pay that price, or should we go somewhere else? And then you have market forces, which then influence, okay, well, surgery center A will do a bundled fee of, let's say $30,000. Surgery center B will do a bundled fee of $26,000. And then now you're competing on the financial basis. And then, of course, then doctors are going to want to differentiate themselves in order to justify differences in price and say, okay, well, let's show you our outcomes. Let's show you how we've gotten better outcomes, or let's show you how you get a better experience. You're going to get what you pay for, right? And you have more traditional market forces than influencing how those transactions happen, as opposed to some nebulous person in an ivory tower somewhere rolling the dice and saying, oh, we're going to pay you today, or maybe we won't.
Yeah, right. Depending on where we're at for our MLR for the year. Yep.
Right, exactly. So one of the things, so it sounds to me, and tell me if I'm wrong about this, okay? So it sounds to me like the mechanism that you are setting up and that you're advocating addresses most of the major pain points that the doctors have when it comes to getting paid for their care, or for the care that they provide. So doctors typically working in an insurance-based model wonder, when am I going to get paid? They wonder, how much am I going to get paid? And they wonder, am I going to get paid?
Yep.
So let's dig into that a little more. How does the mechanism that you've set up address those three major pain points?
Yeah, man. So CommonCare has care wallets that are on the provider side and on the group side. They could a provider could set it as their condition for to differentiate, right? I know physicians don't like to be called providers, but you are a provider and a physician. So like, in as much as you're acting as the provider, you're the price negotiator, you're the business guy, so the physician,
we're the sellers of healthcare.
Yeah. So anyway, you could make it inside of our system. You could make it a condition of your pricing that procedures are prepaid, within 72 hours before the procedure is to occur. So you could require that. And inside of our system, it's like Venmo, so the every pay period, so much money was remitted that employees forfeited through their salary reduction agreement to pay for their health insurance that's being managed by their employer. That money goes into an account that we hold. If the procedure is approved, and it could be pre-approved for a number of reasons, especially if you're already providing. So let's just walk through why physicians should care about this, right? You're providing surgery. Let's say you're a surgeon, because that's going to be your higher price stuff that people would be more concerned about, prior auth and whatnot. This is where the denials become such a big problem and so forth. So no one's going to take you at your word that the surgery you perform and get paid for is necessary medically. So you have, say, a direct primary care doctor inside of the system that sees this patient. They are authorized in that system to have referred, but when they refer, what they really did is scheduled the procedure within our system. So when that's taken place, the employer trusts them, The employer, if it's over a dollar amount, might have also had to sign off on it, but the employee knows this. They can't just run into places with their insurance card and say, look, I'm spending daddy's money today, and the hospital does whatever they do with it. They had to be thoughtful. They had to say, well, is the plan going to pay for this? If they're going to pay for it, what price are they willing to pay? What providers offer services at that price? How do I find that? And the plan will educate them on how to consume medicine that way. And some people kick and scream about that. Too bad, because everybody else in the plan is also bearing your costs when you participate in risk sharing. So you got to behave. So they do that. Now you have a prior auth system that's taken place. You have money that's already in the account. We know the money's in the account. We know who's supposed to authorize it. All the authorization has taken place, and it's on your schedule, and the money's in your account before you ever have to provide services. Voila. That's a great system that's balanced incentives on all sides to try to make business as smooth as possible.
Sure.
So that's how we would handle it. That's how we would handle stuff like that. Could there be scenarios where they can't get authorization for something they think they need or something like that? Yeah. Yes, of course. It is bothersome to me that people will villainize all denials, because you're in a social contract. When you get any procedure done that costs money from the plan, every other member of the plan is a pro rata payer of your procedure. So as a fiduciary for that plan, whoever's managing it needs to be conscientious that what you were getting done is necessary. It's in the scope of what the plan said that they would cover, and that the price that you end up paying for the value you receive is ideal. So you got a lot to balance there, which is, anyway, that the plan needs to manage all that, but that's all the more reason to let a physician group drive, and the only reason they're not driving is because they've accepted insurance companies doing all of this. They don't need to do that. The more physician groups work directly with a panel in their community that's private or employers, the more they're going to get to dictate, what does this group want to cover? What is a reasonable cost for it? How do we decide what's medically necessary? Because that's who should be making those decisions. Just today, they're not.
Sure.
Yeah.
So then it sounds to me, and tell me whether or not this analogy, or let me rephrase. Tell me where this analogy is incorrect, okay? But to use an analogy that maybe a surgeon like myself could relate to, it sounds to me like what you've set up is basically an Amazon for healthcare, where you have a whole, like, let's say, for instance, somebody needs their tonsils removed, right? And so the patient can take a look at a bunch of different people who will remove tonsils and say, okay, well, I can have doctor number 1 do it. I can have doctor number 2 do it. I can have doctor number 3 do it. Doctor number 1 costs this much. Doctor number 2 costs this much. Doctor number 3 costs that much. I've heard good things about doctor number 2. He costs a little bit more, but I know that I also have this much money set aside to pay for this, and it falls within that. And so then as soon as they click, purchase, then the money that's set aside by the employer gets put basically into an escrow account that you hold, right?
Yeah.
And then as soon as the service is provided, then that money gets transferred from the escrow account directly to the doctor or whatever account the doctor has set aside. But all that stuff is already set up so that you're not having, as a doctor, I'm not having to deal with denials. I'm not having to wonder, when am I going to get paid? Because my contract says when I'm going to get paid. If I specified, like you said, 72 hours beforehand, I'm going to get paid 72 hours beforehand. I'm not going to wonder how much am I going to get paid, because that was already determined before the patient even got on the table. And I know what that is. The employer knows, the patient knows, everybody knows how much it's going to cost and who's going to get paid and how much they're going to get paid. There's a lot of transparency in all of that, which, as I understand it, is great for the employers, because they're not sitting there wondering, well, okay, how big a bill am I going to have at the end of this month? They know exactly what it is, and the doctor knows exactly what they're going to get paid. Did I summarize that okay?
Yeah, all very true. I mean, if anybody said, why aren't these things happening? Why don't doctors work more directly with employers and whatnot? Well, some do. Some are. They're just kind of hard to find out what they're doing, because they're sort of just like happy in their situation, and there's not a need for them to scale or advertise nationally what they're doing or whatever. So, the only place I would abhor being compared to Amazon is we're more of an open source vibe in what we do. I want to make it easy. I want to lower the barriers of employers controlling their own plan due to legal processes and money processes and reporting. And I want to lower the barriers for them to contract directly with direct care providers due to those exact same problems, lower the barriers. But in each locality, I would like them to operate relatively independently. We don't want to, Amazon is in this space already in direct care and otherwise, and I have plenty of concerns with how a top-down model is likely to pan out.
Sure. Sure.
Yeah.
Obviously, there's some holes in the analogy.
That's okay. Yeah. No analogy is perfect. Yeah.
Exactly. But I think, thank you for clarifying that, because I think it helps make this conversation a little bit more digestible for people who aren't as familiar with this part of the industry. So, so then tell us about some of your success stories. What have you seen where you're working with the doctors that you're working with, where this has made a difference for the doctors and for the patients and for the employees and employers?
Yeah, well, as a realist, it's just barely starting to. So there's as much kicking and screaming as anything happening right now. So yeah, people are, this is like an abusive relationship. There's no reason people can't leave. That's the funny thing is I see calls for Trump or RFK now to change laws around PBMs or this and that. And I'm like, that's all fine, but you don't need any of that currently. You don't need a PBM to buy meds right now. You don't need that. What you can find a wholesale cost for meds, and there are plenty of people that will dispense them to you for a very transparent, reasonable fee. There's no reason for this complexity other than this is how everyone is trained to consume it, and they will quickly doubt any other way. So most of the space is still very full of that. We are tracking claims. We are mapping cash prices next to network prices. With 90% of our bandwidth right now, we are publishing and gathering data to make the case why this is necessary. We have stakes in here, and I'm in North Carolina, and we have a direct primary care practice here that actually operates. And for them, the biggest success stories are just that they set up an adjacent plan. So most employers won't ditch networks day one cold turkey. What they want to do is they want to offer a secondary plan, which is perfectly legal and easy for them to do in our world. That normally is hard for them because their broker or their carrier is like, can't offer two plans, So we'll just offer an adjacent plan for anybody that wants to participate that advertises a little bumpier process and lower premiums and a little more hands-on consumption of healthcare. They'll get in a direct primary care. Yeah. Yep. And yes, correct. And they will, yeah, man, I can't wait for more numbers to come out about that, right? It's anecdotally, yeah, way better care, way better. It's just, as any doctor knows, studies are hard. It's really hard to prove quality of care. Anyway, because you can move the goalposts so easily. But anyway, the success is more like every year those plans have an increasing percentage of people that join. They have an increasing percentage of people that contract with direct primary care, an increasing number of people that went to privately contracted physicians instead of just going to the hospital for an inpatient or outpatient procedure. We have probably the easiest success is the percentage of people that have their meds dispensed directly through their direct primary care practice is sky high right from day one. So that's probably the easiest and biggest success right now. People are so confused about meds prices and how to source them, and so knocking down prices there. So our biggest victories are that it's easy enough to get started. People are confused as heck about all of this, but when we start, we're up to our ears in work. So for a physician that wanted to start, how do I start in this? If I'm just kind of on, I'm going to go against the status quo or whatever. It's yeah, but enough people are familiar with this that when we open up shop and start somewhere, we can barely keep up. So I don't know that we're making a huge dent in the landscape yet, but we're making a dent as fast as we can get clinicians that can do it. And they're staying full and then some, and we're expanding as fast as we can. And wherever we're doing it, it's growing. So there's a decade worth of change to digest here. But for those that want to engage in it, the biggest success is that it's wanted And the hardest part isn't figuring out if it's wanted, it's figuring out how to manage like growth. Yeah.
That's awesome. That's so exciting. So what you're proposing, what you're doing, what you're actually doing. So this is not theoretical anymore. This is concrete. You've got concrete results. You've got people who are doing this, and it's not just some some pipe dream, but you have real patients. You got real doctors. They're interacting with each other, and you're saving patients money. You're saving employees money. You're saving employers money, and you're putting more money in the pockets of the doctors, all at the same time. So basically, nobody loses except for the insurance companies.
That's right. Yeah. So our fastest growing area right now where this is really happening is small employers, actually, with less than 50 full-time employees, who normally either don't offer anything or they offer some off-the-shelf insurance policy that's just terrible. And incredibly, when they do that, they compete with the federal premium tax credit for their employees. They erase that for their people, which is like $10,000 per employee on average in this country. And they just spend their own private and their employees' private dollars in place of a federal tax credit, which is just so wild. And so when we go in and implement, it's like a partially employer-sponsored plan. There's a way to do it so that they can capture their premium tax credit and still have a group enrollment experience. All that money is freed up to spend on direct contracts with doctors or other similar things, which is kind of what people have done with like HSAs over the year. But instead of just driving the money into a savings account, we try to drive it to the end solution instead, which is a huge.
Sure.
Maybe there will be regulatory changes on the horizon where people can do both. Maybe HSAs will become a little freer for the individual that's not participating in a traditional high deductible plan, but we'll see. Anyway, that's where the biggest growth is, and a lot of that is happening. The growth in the larger employer space is just slow moving, but there's lots of promise there, and there's a lot happening. It's a little more cumbersome. The growth in the individual space, people just us marketing direct primary care directly to the public on Facebook, YouTube, Google, is also very successful, has a very strong ROI from like a marketing perspective. It's very doable. So yeah, those are way encouraging that the small employer and direct to consumer markets are very supple for physicians, providers that want to go into this direct care space right now. There's a lot of demand for it.
That's awesome. So then, again, keeping in mind that the majority of our audience is medical students, residents, fellows, people who are just out of training. There's a lot of talk. I've heard this from medical students in particular about how there's no point in going into primary care. I recently heard a conversation between some residents, trying to decide whether or not they wanted to apply for fellowship and go subspecialize, because they said, well, primary care is dead. You can't make any money. There's no way I'm going to be able to pay my debts. I'd love to be able to take care of patients, and do primary care, but it's just not possible. What do you say to those people?
Well, financially, that's definitely not true, but in the insurance model, it might be. Mm-hmm. So that I heard that Stanford didn't enroll any primary physicians into their med school last year, which for the first time in history, which is crazy. So can't argue with that. I mean, obviously there's something there, but if you wanted to go into direct primary care, it's certainly not dead, and it's just getting started. There will be, just like on-site, off-site clinics did, there will be like some ebbs and flows. People will figure out things that don't work. You'll have bad actors that spoil people's view of this, and so on and so forth. You'll have venture capital that leads it down the same course that all the rest of medicine has gone down. But for a practitioner that wants to hang a sign on their door and be a direct primary care physician and take care of, like, by volume, 80+% of people's medical needs, there is a huge appetite for that and will continue to be. And my prediction would be that the more regulatory changes we see on this front, the more confused people will be, the more happy they would be to have a simple one-stop shop for most of their needs, and then insurance for the catastrophic what ifs. Yeah.
Sure.
So financially, it's very viable. Philosophically, I'm a software developer. There are lots of specialized software developers, and one of the biggest problems that we have in the whole space is very few people that know how to manage an application. I've hired lots of guys that were a senior developer at some organization, highly specialized, and they are a hammer and they see every problem as a nail. And you could see the same problem in medicine. And when you bring those guys into a smaller organization that needs them to wear several hats, they cause a lot of problems fussing because they don't know how to manage the greater architecture of what they're dealing with. And medicine sees a lot of this too, and it's very frustrating and difficult. So if there are lots of specialized guys, there's a big need for physicians that can bridge the gap between the average Joe and how do I tackle this very specialized situation. Like, that's needed, because anybody that's super specialized and has spent a lot of time and money getting there, they are a bit of a hammer and they're going to see everything as a bit of a nail.
Absolutely. So then let's say we got some medical students who are trying to decide, or better yet, we got some residents who are trying to decide, I'm thinking about this primary care thing, and I'm maybe now curious about direct primary care, and they've heard what you had to say about North Carolina, and they're like, I wouldn't mind checking out North Carolina. What would you? How do they connect with you? Are there opportunities for doctors who are interested in delving into this space in your neck of the woods?
Oh yeah. In North Carolina, if we had a doctor that wanted to entertain opening up a panel here, we would help them procure their real estate. We would help them get their first 100 patients on the panel while they're getting paid something predictable. We actually partner with them and do it that way. Of course, there are some strings attached to that. I think we're pretty transparent about what they are and like how we work with people. But if they wanted to do it on their own, we would platform them and offer their services to groups that wanted to offer direct primary care as a service to their employees. We don't limit what employers can enroll their employees into by any kind of proprietary preference. So in other words, you get a group that has 30 or 300 or 3,000 employees in North Carolina that wants to start offering direct primary care more seriously. They can put their video and card in there to say, hey, come and use your employer sponsored dollars for direct primary care with me. Same for health shares, and even some of the cool like Clearwater benefits or some of the insurers that are like not ACA plans. They will offer direct primary care baked into their premiums, or they'll offer a version where you just get a discount if you already have it. And so we will help pair them with people that are enrolling in those policies or health shares as well. So we have several platforms where we can feed them business.
That's awesome.
Yep.
So now, how about direct specialty care doctors? What do you see as the future, or even the present, of collaborating with direct specialty care doctors? Whether it's like gastroenterologists or rheumatologists or surgeons, fill in the blank.
Yeah, right. And so there's an easier answer for this for an OBGYN than for a neurosurgeon, because of the size of populace required to fill their panel. But there isn't, the current reality is the most sophisticated businessmen doctors or businesswoman doctors are able to contract and manage surgery centers or other similar arrangements for their practice, and we can contract them with employers all day long because they have all the pieces. I think in 12 months from now, we will have enough panel that we could go to a zip code or set of zip codes and say, here's how many people we have across all employers in this zip code. Here's how many cancer patients we had last year in this geography. And we could start to buy out direct care contracts by filling panels for specialists. Facilities are by far a bigger hindrance there than being able to do it with the doctors. So in a short amount of time, CommonCare is, I would explain like our goal post for like when we have achieved something that we really feel proud of is when we have secondary care direct contracts as like a norm for what we're doing. That's what we really want to get past with primary care into the secondary and specialized care, and have percentages or whole panels for specialists filled with private contracts. Like, that's what I would prefer.
That's awesome. And that's really exciting. So are you guys limited to just North Carolina, or are you growing?
Oh no, yeah, we do this everywhere. We just don't own we don't have any boots on the ground as far as stuff that we own in medical practice in other states.
Sure. So, so let's say we got somebody in Nebraska, that's interested in collaborating with you, whether it's a primary care. Let's start with the primary care doc scenario, and then we can, move into the specialty care doc scenario. What would that potentially look like?
Yeah, if they're like, if they said, hey, I'm interested in filling a panel here in Nebraska, we would go to our market of employers there, and we would be willing in any markets like that to spend our own ad dollars to test what it's like to go direct to consumer. And those two markets may be different, and we're going to probably race them against each other and say, how do you want to fill your panel? For a doctor, you could fill your panel with 200 employee company. The problem is you could lose that whole panel next year's renewal. So I think it's very smart to work with, when you're first starting out, to work with a lot of small employers that bring you 2 and 10 and 20 people at a time, and to have a strong direct to consumer marketing flow so that you can, you're just a lot more diversified in your panel that way. So that's how I would recommend starting it. Although if they were like, I really want to work with a big employer, okay, we could target that as well. We have interest in targeting it because we run our marketing around the idea that they should be pushing insurance to the background and spending more of their dollars directly on providers. We don't charge direct primary care or other direct providers anything to use our platform. We need their services in order for our model to be viable. So we're willing to invest in them being successful as a stake in our kind of tent as we try to expand what we're doing. Yeah.
Awesome. So as we wrap up here, I have two final questions for you. Number one, again, keeping in mind who our primary audience is, if there's one thing do you want these doctors to know about what you do and how it's taking better care of patients, what would that one thing be?
That's a great question. I think that I'm so shocked that inevitably this conversation, it gets down to a moral or axiomatic discussion, even with HR reps at companies. So, and I don't want to see our country move to the German model, despite how many voices there are to push for that. It's not accurate. And you can't start the healthcare journey by trying to solve 300 million Americans' financial and healthcare problems and decades of horrible health all at one time. You have to do something that works. You can't fix food in our country. You need to grow a garden. So I would say if you really want to be a moral driver, and this I think lines up with the financial incentives too, although I can't say I have metrics to prove that. But if you want to be a driver for change, you should set up one successful private, super decentralized private practice that has as direct relationships, doctor to patient, as possible. And if there was a bunch of those, you might find that the big problems were solved too. But you can't. The mistake that our whole country has made is thinking that you can write a policy and have it fix these problems. And you cannot do that. You need to grow a bunch of gardens. So that's what I would prefer doctors that were thinking about this to be like, I just want to make a fantastic solution in my zip code.
Sure.
We'll see what happens after that.
Sure. Local solutions for local problems, right?
Yep.
Subsidiarity at its best. Okay, so then the final question. How do people get connected with you? How do these doctors, these employers, anybody that has heard our discussion today and said, you know what? I want to know more about that. I want to get plugged in, or I at least want to find out more about whether or not this is the right fit for me, whether or not working with you guys would be a good idea. How do they do that?
Yeah, CommonCare.org. So we're super accessible there. Our platform is meant to be tech engagement first. And we have by the time this airs, there will be a brand new iteration of our whole application that'll be live there. So yeah, I think anything that you'd want to access here, you would begin there. Although we're pretty accessible. We're not you can't reach a real person type of tech company. So if they have things that aren't solved directly through commoncare.org, we're easy to reach through there as well.
Awesome. That's exciting. Do you have any other last thoughts before we finish up here?
No, man, I think what you're doing is awesome. And I think that direct care, if things go in a direction that I'd like to see us go as a country, direct care is the future. Direct care is a bright future for medicine of all possibilities. It's my favorite that I can envision. Yeah.
Yeah, I would agree with that 100%. And not only is direct care the future, but it's also the present, because you and I are doing it right now.
Correction accepted. I agree.
All right. Well, thank you, Tyler, for joining us today on the Direct Care Movement podcast. It was exciting having you on board today, and I'm sure our listeners are equally excited by the conversation we had today. If those of you who are listening found what we talked about today interesting and you want to know more, then please subscribe, listen to the rest of the episodes. Right now we're set up to do 4 full seasons and possibly more, depending on whether or not there are enough of you that are interested in more discussions like these. Make sure you share it with a friend. Tell somebody about this. Don't keep it a secret. Tell somebody about the solutions that we're discussing on the Direct Care Movement podcast so that we together can be the revolution. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.